have some extra time for people to get into this call, and let's start this webinar. Thank you for your kind patience.
Bom dia para todos. Estou por estar aqui.
Buenos días, buenos días.
Buenos días.
Solo vamos a esperar un minuto más antes de empezar el webinar.
Let's wait just one more minute to start this webinar and get more people into this call.
Bueno, entonces para no perder más tiempo, vamos a
All
empezar.
right, let's start now with activity today. Good morning and welcome to the webinar seminar on the today's logistic and seminar web. This is our pilot project to train people on the use of the semi-quantitative fast the standard GSPD for the management of malaria vivax in Colombia. We have today's agenda, and before starting, we will talk about briefly about the GORCOP. Then we have questions at the end of the session. The practice communicating GSPD generated by PATH is a collaboration on researchers on program and control of malaria, physician committed to the advancement of the diagnostic of the GSPD and supporting the safe access of the correcal of malaria vivax through the investigation. With that, I would like to ask Camilo Parchola, who will be moderating this session. Camilo Castillo is your program management on the strategies for Latin America. Has more than 7 years experience as manager of information on the Ethics Commission on the investigation of COBAP of Brazil, as a technical consultant on science and technology on the Ministry of Health in Brazil. As Camilo has worked also as a consultant for the Regional Office of Science Research of UNESCO for Latin America and the Caribbean in areas related to the bioethic and ethics of research. As a professor, he worked over 10 years nationally and internationally, teaching bioethic and international relations. Camilo is licensed on international relationships and doctor in bioethics. He has been a postdoctoral intern on the Cátedra UNESCO of Bioethics from the Brasilia University. Camilo, please go ahead. Thank you for the presentation. My name is Camilo, and I will be moderating this webinar seminar. I will just give some ideas of this webinar. This will be recorded and distributed by the end of the session. Will be accessible to the core co-op um, areas recording, and we have the English and Spanish interpretation. You can listen into the interpretation mode tool. There's a globe on the bottom of your screen, and you can click on it, and then you can decide which language you want to hear the session on. The presentation will have 30 to 35 minutes, and then we have some time allocated for questions and answers. Please just think about some comments and questions about this. So just send your question through the chat, or just raise your hand and activate your microphone. At the end of this session, just before asking your question, just share some information about yourself, where you're from, what's your name. Before starting, we'll tell you a little bit more about our Lina Zuluaga. Lina is microbiologist, a master in epidemiology on the Antioquia University. She works on the public health office and associated researchers on the malaria group. Nina, on research on malaria, has been focused on looking at the treatment and evaluation of the development for diagnostics, and also on getting records of infection on plasmobibas. Teaching, she participated in upbringing the OMS, WHO's on the implementation of Latin America through the Antioquia University institution that she's part of. Lina, as you know, in this slide, she will talk about in the pilot educational program to train health professionals and community management managers in on the use of the fast and quantity standard GSPD for the management of malaria in Colombia. Those part of the efforts on the PAVE. PAVE. This is the alliance to remove PBBACs on the transmission. Pay for PAVE is has path medicine for malaria prevention, or MMB, and has the global health strategy GSS as a coordinator as in Colombia, Brazil, and Peru. Lina, please go ahead. Thank you. Good morning to you all, and thank you, Camilo, for the presentation and also for the invitation. I'm very pleased to share this experience. As Camilo mentioned, this is an educational program in Colombia. Next slide, please. This program has been executed, of course, by the malaria team in Colombia, and is part of have different people working on it, as was mentioned, on the framework of the PAVE Alliance. Next, please. In this presentation, we will focusing on the 6 point. First, a small introduction on content of the program. Then we will be mentioning the objectives of the program, the methodology related to the design, the pilot workshop, quality components, and we're going to show the results. And then with the lessons learned, and the conclusion will be the end of our presentation. Thank you. Next. It is important to remind ourselves that Colombia is has a very important number of malaria cases for the America region. We have 71,000 cases reported in Colombia, the 60.7 with a vivax, and what will happen in 2023, the proportion it is greater, that having a 68% to this last year. We have two departments that is actually summing up 74% is Choco Nariño, and this treatment of malaria is based on the combined chloroquine and primaquine. Those chloroquine from the stages as 25 milligram per kilograms, administering 3 days. And according to our experience, we have a clinical response that is having a close to 100% to response to this medication. For the primekine, which is the have a 0.25 milligrams per kilogram for over 14 days, similar to different processes. And according to our experience, almost 64% that is receive this treatment will have a new recurrence on the plasma vivax less than 6 months after the first application. So we need to see a new alternative to the treatment of a radical care for or cure for malaria. We have a hemolysis risk on the deficiency of glucose 6 phosphate dehydrogenase. The implementation of these new schemes of treatment for malaria PVAX include to incorporate new tools for the diagnosis, for the detection of the enzymatic activity, through which we could provide a safe treatment based on the enzyme activities. We have the standard GSPD test is a very good diagnostic test for deficiency population, and we see according to the context where malaria is happening. In Colombia, we have different alternative on the treatment of for the malaria PBVAX, and this pilot project is part of the efforts that we are carrying out. Next slide. The objectives of this program first was to design a pilot dedication program that we're going to show you today, evaluate the efficiency of the program, validate the methodology, look at the acceptability and usability of the standard GSPD, explore the barriers and enablers that will impact the use of these tests, and understanding what level of the health system will be this tool implemented. This program has been developed or is currently being developed in these 4 stages. The first stage is the design of the program that took place September 2022. A second stage, the comply um, pilot project to test this tool. And then we have some interviews for the qualitative and quantitative analysis. Now we are looking at the analysis of quantitative and qualitative analysis. We're part of this last stage, that is generate the adjusted education program and the tools that we're going to be showing at the end of the presentation. Next slide, please. Next slide. Okay, so to understand about the design, it's important to show that we are implying some of the strategies and methodology of the active methodology. This program is consolidated in a workshop, a theoretical, practical workshop that is divided in 2 days and in 6 sessions. At the first introductory session, that is for the pilot project, and then when we develop all the theoretical part. Then we had a practical session, and then we have the assessment of capacity on the participants. And session 5 is a focus group, and the 6 is evaluating that workshop methodology. That is for the effect of this group specifically. Okay, so in the theoretical content, we are focusing on the participant will understand the reason why we have to use the test, when and who to use it, and on and how to work. In the practical part, we are focusing on how to do the procedure, how we interpret it, and what is the decision we make with this result. And when we have 3 part, it corresponds to the demonstration on the facilitator on the looking at hair, venous and quality control. Then we have a supervised practice with all the participants have had opportunity to check on those samples. And then we close with the group discussion. And then we see the consolidate the objective of the theoretical and the practical sessions. Then we created some materials that we use, that we try and test it during this workshop with theoretical on the test and the project and online the case study guidelines and a video that is showing step by step for the hair skin graft that we are taking according to the tools that we're designing for the evaluation of capacity or skills on these pilot projects. We have the purpose of evaluating methodology and look at the participant on the use of the test. On the cognitive capacity, we create an instrument that has two parts. The first one is focusing on evaluating the concept or theoretical, and then we have a closed questions concept. And in the second part, we had every participant could select randomly the description, clinical description, and they had to answer to the questions. Is those cases that would apply the GSPD use of these tests or not, and what will be the justification? Next slide, please. For the procedure skills evaluation, we have two part evaluation. The first part, we were providing some results from the analyzer, and from those files they have to record the results and interpret the results. The second part was an observation exercise of neighbors have a list and it's like a checklist of making sure that whether the step were followed through. And then we have the qualitative assessment exercise in which the neighbor who have an agreement whether the participant carry out or not valid procedures. So therefore, they have a correct result both um, for the health test and also the blood test. According to the efficiency evaluation, we use those instruments plus a participant characterization tools. We have a descriptive analysis in which we look at the score of each of one of the participants, both in the procedure and cognitive part of the evaluation. We come up with an overall score, and then we saw and compare the score before and after of the workshop, and then we estimated what will be our media for the size of our instrument. For the evaluation of the methodology, we use three instruments. We use the quality evaluation of the participant when we have a quantitative evaluation through a questionnaire with closed question when we assess content, material, methodology, logistic aspect, and the role of the enablers. And then we have a qualitative evaluation by the enablers that we identify the strengths and improvement opportunities. We adjusted methodologies and materials based on these three factors. For the evaluation of acceptability and usability, we selected instrument validated for the construction of interest. The ones we selected three instrument first evaluated for the technology acceptance models and disability systems, and also the implementation science. We adapted to the Spanish context, and then we have the response. We have the evaluation score that looking at the perception of these potential supplier of tests on 5 point score, and completely agree to completely disagree. For the facilitating and to understand what level of health system could we apply these tests. We have a qualitative focus group, and based on interviews that we build a guidelines for the collection of information, and then directly these guidelines facilitating the validation of the methodology and the program materials. Next slide, please. This is what we selected two areas in Colombia to test this methodology. We selected Leticia in Amazonas department, in which the frequency of vivax is 99.3. Choco and have close to 44, and Antioquia department with Turco y Albagre with a PBVX of 83%. Those areas represent the context in which we have the PBVX malaria. We have 13 to 25 participants per place.
Bueno, incluimos entonces
So
varios
we
tipos
include now different type of participant to represent the context. We have a health promoters. We have a technical knowledge on the different faraway rural places. We have nurse auxiliaries that will have technicians that will understand on the health care are the outskirts, and also the health professionals from laboratory from private and public places that will run the test on the first or second level of care, and the physician that will prescribing the malaria treatment on those medical facilities. The participant of these focus group were for the same participant of the workshop. We selected randomly to 10 to 12 these workshops that were part of this each place, and the interviews focused on admin personnel that are coordinating these diagnostic places. And also, those are the referrals of malaria from the healthcare department. Okay, in total, we including 71% from these four sides, 64 participating in the evaluation of cognitive capacities and procedure capacity. Mostly were women, 80.3. We have almost 10% from indigenous communities. The average in years will be, in age will be 44, and 74% do diagnosis and also provide the treatment for malaria patients. We have a very homogeneous people. We have participants that from the high school, incomplete high school to the postgraduate people. According to the professional profile on the mostly we have nurse auxiliary as 52% or lab technicians that were located in these areas. The community managers that are voluntaries that are almost 15%, and the technicians are 17%. And we have physicians or admin personnel. Next slide, please. According to the evaluation of the cognitive skills, we have a higher score for lab technicians, and compared to nurse and community manager, we didn't find any difference on the age or the location or area of origin. We have the score obtained in these tests before and after this workshop for all the professional profiles. It's important to highlight that we did not include in this questionnaire questions that are related specifically to the procedure, and we have some difficulties on the analysis of the question conditioned by other questions, or that the participant could have multiple answers at their disposal. Then we have a very good and correct response, close to 80%, related to the standard treatment on Colombia and counter indication and the manifestation of the hemolysis. And we have good results on the part of the questionnaires in the way we assess the capacity to decide when we will have to apply these tests and by who. According to the procedure skills evaluation, we have a high performance, greater than 80% for most of the participants. We didn't find any differences on the capacity to do these tests or by profile, place of origin, or age. When we're looking at the qualitative consensus among enablers, we included that 88.4% of the participants were able to carry out correctly the collecting of the samples more venous and capillary testing. The most frequent errors are related to the looking, compliance to biosafety, and the collection of data before doing the test or the procedure. According to the validation of the methodology in general, that both quantitative and qualitative evaluation by the participants were positive or mostly positive, related with the content, material, methodologistics, and the role of the enablers. On the enablers, we identify different aspects of the instrument that we need to adapt, and also the materials that we use for the training. Also, we identify the need to look at the capacity, the interpretation of the results, the communication to the patient, decision making about the treatment. Next slide. Related to on looking at the acceptability and usability of the test, we found a high acceptance with value of 4.5 out of 5. The look 3.5, sorry, the looking at the compatibility with the profile, and we saw just a medium of 3.5 over 5 related to the compatibility with the current work condition that comply with what we found in the instrument to look at the acceptability, in which pertinence and feasibility we had the highest result, but we have a lower scores on items related to the compatibility of tests with the workplace and the facility to implement it by under the currently conditions they have at work. We found that almost 90% of the participants completely agree that on using the test, all the people could be able to use it, and I feel comfortable using it. So we see that 50% that consider that will need some technical assistance in order to use it, and they have to learn a couple things before using the test. Next slide, please. Related to the qualitative components and identification of barriers and enablers, we carry out 4 focus groups, one per each place, and through also 8 interviews that we did it for the coordinator, diagnostic outpost, personnel from the Undersecretary of Health, a referral for the lab treating malaria, and coordinator. You see that the barrier that we identify are classified in 4 groups for accessibility, acceptability, availability, and contact use. So we could say that highlight among the accessibility barriers, those related to the difficulty of access, so that we can do technical assistance due to the conflict or geographical conditions of those territories, of how temperatures that go over 30 degrees Celsius, that could be a limitation to the storage. We have the administration, some barriers that could pose a problem, and the workload that could pose a problem on the places where we're testing for malaria. On financial, we see the no disposal of resources for the allocation of spaces or infrastructure to carry out the test, and the cost for the acquisition. On the acceptability, the lack of knowledge about the test by the medical physician, and availability will be the additional supplies to the kit that they have for the after the malaria diagnosis, and then we need some the collection tools that we need. We need also to provide power in order to ensure the correct temperature for the strips. Also the contact in use, there's a communication barrier between the participant. They see that there could be a denial, a refusal of the patient to carry out a test. That could be no adherence to treatment will be also a barrier. According to the education barrier, we see that the lack of education about the test, the lack of technical assistance, and retraining to those carrying out the test. Next slide, please. The enablers that we identify divided in two groups. The first one is about the disposal, both for the healthcare professionals and also the public care facilities. And the next enabler team is characterized with the portability, the management, on how we are handling the results. Next slide, please. So now we see the lessons learned through this program. We consider that the methodology, the content, the evaluation were very well accepted by the participants. One of the lessons is that both to 4 to 5 participants per group per enabler were very good and adequate for the practical session. We see that we need to include a visit to the workplace before implementing the test in order to test the specific condition of these each one of these sites. In a theoretical session, we need to see put more emphasis on the treatment schemes based on the test results. On the case of problem, we can use it as a good strategy to summarize what we learned on the both theoretical and practical sessions. We saw that the instrument could be looking at the putting more emphasis on the scenario when we use the test treatment according to the results, and then the methodology that we use for the practical part were very well validated, because the exercise of observation and procedure and interpretation of results show correctly if the participant had the skills to do the procedure correctly. Um, this reflexive evaluation allow us to identify specific aspects that should be reinforced during the retraining workshop on through the visit that we do through the technical supervision, perhaps. Next slide, please. Okay, this program have different limitation that we recognize. The first one is the evaluation of the immediate effectiveness after the workshop that could be biased, not including the workplace visit we needed to do before starting the implementation of the test, because the barrier that we were able to identify is not only the context, specific context could change according to what will be fine in this program. It is important to consider that we are not including any aspect on retraining to and this could be based on the frequency of the test. And then we need to check on the quality control that we didn't go over on this pilot project, but we need to involve the public health labs and the International Institute of Health for a follow-up. As a product of this pilot project and the final stage of the program is adjusted, we are in a stage to finish with this toolbox that is divided in 3 group of products based on the experience that we have with the pilot project. The first group, it is on the carrying out the test and interpreting the results, and it is included on the video, the step-by-step guideline that we use on the workshop that we were adapting or reinforcing for this final delivery of this toolbox. It is interpretation for the result interpretation and the selection of the treatment, and a file to record the results. There's a group of material to facilitate the communication between the people carrying out the test, and the patient. And then we have four products and another group of product that is uh, directed to the enabler, the one carrying out this program, and they will use the test. Some of the materials, those were the one presented before, but they were adapted according to the lessons learned, and we included a manual for the enabler. Next slide, please. Just to finish up, I would like to provide the conclusion of this pilot project. The standard GSPD test could be implemented in any healthcare outpost or hospital in which we carry out the malaria diagnosis. Uh, o- eh, if and only when we dispose of all the supplies to take in the samples and to carry out the test, like having adequate conditions like space and also the storage of supplies. Our second conclusion is that we have more opportunities to implement these tests in hospitals or public lab or located in the urban areas due to the fact that they have access to the supply and to keep a better control, quality control over the procedure because it will be easier to have technical supervision. The third conclusion that we need consider that we need to implement clear strategies to the follow-up and technical support with the support of public health department labs. That's also outstanding on this pilot project, and we consider on the test that could be carried out by a person with just high school basic training with some reading and writing skills and has some experience on the malaria diagnosis and has been certified to carry out the GSPD standard. Any people that participated in this workshop could do the test. The challenge is not on the procedure itself. That's the most satisfactory result, but we have a greater challenge on the cognitive skills and the we believe that the team should be a multidisciplinary team for enablers. This could be very helpful when you have different knowledge of each participant. And then we see that this program could be replicated using the education materials and evaluation instrument, adjusting into each one of the contexts. Thank you so much. This is all the participants of this workshop. We thank everyone. This is the picture of each one of the workshop that we carry out. And I'm waiting for your questions or comments. Thank you so much, Lina, for your excellent presentation of this very interesting initiative here in Colombia. We see that are generating many responses and many reactions. We can open with the first question. We invite you to raise your hand to ask questions or just um, write your question in the chat box. We reiterate just before asking your question, just let us know where you're from and what's your name. So, Lina, your first question for you would be the following: how you ambition the Antioquia University team, the role of multidisciplinary team to develop these and other education program apart from health. What other areas of knowledge were needed. So as soon as Lina finished answering this first question, we can open the floor with any questions that you may have. We can actually pose a question and open your mic. Thank you, Camilo, for your kind question. As we mentioned at the end, it for us is fundamental the integration of different areas from the design of the program and also, I mean, when we saw the challenge on the Antioquia University, we consolidated this team based on the health education, and we also have two anthropologists. one educator, one physician, and two microbiologists that were part of the beginning of the design, and this was fundamental. This dialogue of knowledge allow us to consolidate this program and to make it successful. Then the development of this workshop on each one of the sites, the territorial approach and ethnic and differences. I think that it will be very important on this knowledge dialogue. I think that we can bet on this not only in this educational program but in any other program. Thank you, Lina. That's for sure. This is approach that you follow was fundamental because effectively help and bring in many type of knowledges. We have a question on the chat box. The Alberto Castaño asks what recommendation were given by the admin workers on each region for a future implementation. I think that the first call was to the backup by the Ministry of Health. I think that could be able to go to the implementation stage of the project because it's a pilot project. Also, a call for the supporting material that could be later implemented. I believe that now the admin, the core outpost coordinators response was just to consolidate these toolbox. That's why we reach this point. And as we've mentioned that the challenge is not that the participant were able to do the test, but to understand the importance of the test and understanding what how it is important to have it. Having a basic competence based on the communication with the patient, how to transmit this information to the patient. How can I tell the patient that they have a deficiency result on the enzyme? How can I provide that result and convey that message? That's how we were able to comply with and achieve that with this toolbox or by the use of this toolbox. But thank you. That's very fundamental for the manager having these toolbox available and to be used when there is when needed. I invite you again to just raise your hand and ask your question, please. Let us know where you're from and what institution. My name is Marta Suarez Muiz from Piocruzes on Rio de Janeiro. Lina, that's a very interesting and very important work that the technology that is arriving to the market and is needed. I have a couple questions. The first one is related to the fact when the patient has a result, how can we provide the result? It has a result that they will have for the rest of their life. They will have a document that they have a deficiency for median deficient. That's the first question. And then I have another question is that the people that were trained, this semi-quantitative or qualitative only? Lina, please go ahead. All right. Thank you, doctor. Regarding the first question, we as the toolbox that we designed, we have contemplated a record for the results, and we had the amount of the enzyme and the evaluation is deficient, intermediate, or is regular, or we design a some papers for the enzyme results, and for the patient that will have deficiency on the site, we have some material, a paper with recommendations, some instruction with the alarms, symptoms that they could be expecting after the diagnosis. So that's related to the first question. Those materials are new, and those are products that were based on the adjusted program, and they are there when we test and we see how does it work, and how the community respond. According to the second question, is a semi-quantitative is uh, throwing out result of enzymatic action and to complement the people doing a test is responsible to take that value and classify if they have a intermediate, regular, or deficient, and assign the treatment according to the policy of each country. We have a tool there that will allow to facilitate the interpretation of the result that we have from the tester. Thank you. Can I continue with another question? Yes. Marta, just allow me 1 second. If there are the questions, just raise your hand and pose your question. So, the interpretation of the results on women are a little bit more complex, correct? How have you seen it in the field, the response by the people that you were training? And the results are in the women's and men's are quite simpler, but in women is quite complex. So how do you did that? In women, we have like three possible scenario: deficient, intermediate, and regular. And in men will be normal, regular, and deficient. I think that that was the general indication that we have, and through that we built the tool in which on that group, the intermediate level, we are classifying only women. So in the intermediate group, we're looking at the treatment in the case of Colombia for period of 14-day treatment. We explain, but in the theoretical, we explain it very broadly in general with a we don't go over the type of profile that we have with the participant. We don't explain the side, but we just let them know the general information on what represent the intermediate. But we are emphasizing the treatment, safe treatment for women that will have this level. So that was the indication, and also the material includes this classification according to it. Just to add on, of course, the material topic, the use of colors, that's fundamental to explain to this type of population, and having a specific case for this more complex case in comparison with the male group, so we can see the design of the material. So we have Gonzalo next, and Martha, if you have more questions, then we can come back to you. Gonzalo, you're up. Uh,
Gracias, Lina, por una presentación tan completa y tan comprensiva, un estudio muy fenomenal.
Thank you for this very comprehensive presentation based on what Martha was saying and we're discussing now. What I understand is that this material of on assessing the results of the enzyme test were tested on the study with the users, along with the users of a test and those that will be providing the support. Are there some interests or activities on looking at the usability and the understanding of these tools and the patient that will be reviewing it and looking at it? The last comment from Camilo, the understanding is what we're trying to get, right? I'm not sure if your team or other team in this call are thinking on looking at the comprehension on the side of the patient. Thank you for your question. Yes, these material as were built during the last part of the program when we're adjusting, we are including two activities. The first one is still outstanding for closing this pilot project. We could have some feedback from the coordinators of the outpost in relation to the material, because of course we see some were designed on the framework of the project and were tested, and some other are new. And we are in a point when we have to check the feedback both using the test and the patient. So we are thinking about the implementation of the test, and then we can have some material that were designed and these final stage on the tool, and also including the toolbox. And I'm sure Camilo would like to say something else. The same methodology on the perspective, not only terms of statistics and rough or hard science, but also methodology that is interactive and iterate. As Lina mentioned, some of the materials were ready and validated, some others were created as a result of the experience in the field. And the idea, as Lina mentioned, those are based on the feedback, and on the basis that we will have some conversation with the manager, but also on the pilot project for the implementation. We have more questions. We have like 7 more minutes to listen to you all. I'm not sure if anybody else will have some questions. If not, Martha has some questions. I think it's very interesting. The implementation. I have a couple questions, but if you found lower score on the Venus versus the capillary, and also the place of the testing. Lina, go ahead, please. Thank you, Martha. Regarding to the Venus testing, most of the participants that do that diagnosis based on the capillary, so it was something new. And then I think the biggest mistake is that they were not shaking the tube. And they have a previous sample that we took from the patient. They forgot to check the tube. They looking at the testing, or it's not part of what they do. We try to incorporate this sample, although it is not part of the malaria diagnosis. Is based on the hair test, but we were looking at people from the lab, and in some scenarios, to use these venous sampling. So that's why we decided to include it, the testing, and also theoretical and practical, and also part of the evaluation. But some of the adjustment that we consider for the program and the instrument is precisely is to replace these hard on the venous testing, because we consider that effectively, even when we're not all using the venous testing, they also should use a quality control. And I'm not sure if you can go a little farther on your question about the place.
Según el lugar de la prueba. No sé si el lugar de la
I
prueba.
understood that you have a lower score based on the place of, like, is it a hospital versus a rural. No, according to the place. Now, there's already no difference, not only in the cognitive nor in the evaluation of the procedure, but we only see difference on the evaluation of cognitive differences. On the profile, that we have a better score on the um, lab technician. They have more studies on, but for other spectrum, we didn't have no difference whatsoever on the procedure. But we also saw that there are more common mistakes on the professional than the manager, because they have more capabilities to follow up through with steps. But based on the places, I just mentioned the places where the workshop. Uh, okay, it is not really scored based on the place, but we have a couple more minutes. I think we have questions on the chat box, or you can just raise your hand and open your mic. I think Jonathan Noboa. Please go ahead. Jonathan Noboa from Colombia. Um, I wanted to ask you, Lina, a little bit more about how can we extrapolate these experience to other countries. I understand this is a program that it's go over or beyond a just training people to take a test or a sample. It is more of an educational program. It will another country or people from other countries here that works in the malaria program and I consider interesting and important to replicate it. Can we do it? Because the methodology that you use is very specific. The popular education that perhaps some other countries that will have other methodology and they cannot be able to replicate it, or it is we're able to replicate it on the training, on the procedure, on the test itself. Um, what do you think if I am a malaria, if I have a malaria program, uh, how can you recommend this program to them? Thank you so much for the question. I think that this methodology, the material could be replicated for in other countries. So what we consider first is that we need to adequate it or just look at a different part of the Ministry of the treatment that they're using on the toolbox that we are creating. There's one thing that we consider the enablers manuals in which we provide all these general consideration and be able to carry out the methodology so that we can replicate it. It is important to adapt with examples on each one of the concepts. The one that we included could be applied to the Latin American context, and the other part it is important is that we are able to carry out or put together a team that can actually carry out this type of work and the materials. I think that we can adjust it to different contexts and countries in Latin America. And thank you, Alina. Just to clarify that the methodology has been taught not only for a specific context, but to follow through some features that are kind of general, like the existence of community that have some access, difficulties on access to health care, and then we can use that to replicate it. There are some specific contexts or cultural features that could be highlighted or included, of course. Can I ask a last question, like a follow through? I believe that, Lina, there should be some other methodologies for training and education. Uh, I wanted to know what was the thing that that brought your attention. I'm not an education expert, but I believe that must be some other methodology for this type of training. What caught your attention on these popular um, education methodology? I'm not an expert either on education, but what we discuss among our group is that in general, with other methodology, they have a more cognitive, of theoretical. We bet on look at some other aspect and procedure and also the attitude, and then we're recognizing that the territorial and how, I mean, the participants and understanding the diversity and what is bringing up the traditional scope, that is the difference. I think just to add on, we see the popular and we have a popular education and education by skills. Those are strongly related to hierarchy. We don't consider that community, as Dina mentioned, and we are basically discussing and sharing knowledge. I think that's the end of our webinar and for today's session. We really appreciate the participation. It was great to listen to you all. And Lina, thank you so much for your time and for preparing this presentation. Excellent presentation on this education pilot project on the training of personnel to use these tests on malaria vivax. Anything else before we close? Thank you so much for the invitation. This was very positive experience for the Antioquia University team. Thank you everyone, the PAVE Alliance and all participants. We hope to find yourself in another meeting. Thank you so much, each one of you. Thank you.